this anesthesia rapid revision session. In this video, I made sure to cover all the important questions as well as topics, and I made it very crisp and concise manner. So without wasting any time, let me get into the topics which I am going to cover. Those are history of anesthesia, pre-anesthetic evaluation, anesthesia machine as well as circuit, airway and mechanical ventilation. As you all know, anesthesia is divided into general as well as regional anesthesia. So in general anesthesia, we'll discuss about inhalational anesthetic agents, intravenous anesthetic agents as well as neuromuscular blocker. And in regional anesthesia, we are going to cover the topics like local anesthetics, central neuraxial blockade. In this, there are subtopics which we cover are spinal anesthesia as well as epidural anesthesia. So the first topic is history of anesthesia. The first question here you have to notice, that is, who is the father of anesthesia? He is none other than John Snow. This is the question you need to remember. The father of anesthesia is who? John Snow. Now coming to the second question, who is the father of modern anesthesia? He is W.T.G. Morton. So why we say him the father of modern anesthesia? Because he has publicly demonstrated the anesthetic agent of ether on the day of 16th October 1846. That is where we have decided the World Anesthesia Day. Now coming to the father of spinal anesthesia, he is August Baer. So this is the person who is the father of spinal anesthesia. Now after the history, what we have to do is pre-anesthetic checkup. What it means, before giving anesthesia, what the checkup we have to do. The core focus which you need to do is, there are three main steps which we need to follow. The first step is airway assessment, and the second one is history and their medications, and the third one is fasting status. So before giving anesthesia, we need to make sure to follow these three steps and get into the final decision. Coming to the first step, which is airway assessment. So how we are going to do the airway assessment? We have two main steps. The first step is we ask the patient to open mouth, and what we are going to check in there is Mallampati classification which we have. I'll go detail with that, as well as there is inter-incisor distance. What does this mean, inter-incisor distance? The space between upper incisor plus lower incisor. So the space which you can see here, the distance between upper incisor as well as lower incisor, this is nothing but inter-incisor distance. Now normally how much it should be? 4 to 5 centimeter. Now coming to the Mallampati classification, so why are we doing the airway assessment? The main reason for it is for the intubation process. We need to check this airway assessment so that to make our life easy for intubation. So the inter-incisor distance is how much, students? 4 to 5 centimeter. Now coming to the Mallampati classification, we call it this way because the person who have introduced this is Mallampati, so we are calling it as Mallampati classification. So what he told is, there are stages, there are classes which he have given us. In class 0, we can see when the patient open his mouth, we can see the hard palate, soft palate, uvula as well as tip of epiglottis. In the class 1, we can see the hard palate, soft palate, uvula with tip as well as tonsillar pillars. In class 2, what you can see is hard palate, soft palate. You cannot appreciate the tip of uvula, but you can see the base of uvula. In class 3, you can see the hard and soft palate only. In the class 4, you can only see the hard palate. So by itself, we can say clearly, the more you see the parts, the more space you have. So it is very easy for the intubation. But when you see the less parts, it means there is less space when he open his mouth. So that is where the intubation process is very difficult. I will show you the image. Now here, if you can appreciate it, the ease of intubation, if you see, you can see here the uvula part. There is soft palate as well as hard palate, which you can see, as well as the tonsillar pillars. So this is class 1. And here you can see the uvula part as well as soft palate. You can also see the hard palate as well as tonsillar pillar. So this is class 2. Now here you can only see the soft palate, and this is the hard palate. This comes under class 3. Now the fourth one, only the hard palate is visible. If you can see it very clearly, only the hard palate is visible. So we consider it under class 4. These are the 4 classes which we see in our Mallampati classification. So it's very obvious that class 1, 2 are very easy for intubation, and class 3 and 4 are very difficult for intubation process. Now coming to our second step, what we do for air assessment, we ask the patient to lift their chin. So when we ask the patient to lift their chin, what are the distances we are going to measure? Those are thyromental distance as well as sternomental distance. From where to where we are measuring, it is nothing but from thyroid to mentum. The distance between, you can see here clearly, this is the thyroid region and this is the mentum region. So you will measure the distance between thyroid and mentum as well as from sternomental distance, from the sternum as well as mentum distance. So this is the distance we are going to check. Now let's see the mouth opening and chin distances. What are the Mallampati classification as well as when I ask the patient to lift the chin, how much distance is the normal for the intubation process? So what are the distance we'll do for the interincisor distance? The normal measurement is 4 to 5 centimeter. We consider it as normal as well as very easy for the intubation process. But when it is less than 4 centimeter, it is a difficult airway. Coming to the second one, that is thyromentum distance. When you see, the normal is more than 6.5 centimeter, but if it is less than that, it is difficult for intubation. As well as if you see the sternum and mentum distance, the normal is more than 12.5 centimeter. If it is less than that, it is very difficult for intubation process. Now, when there is a restricted opening, for example, there is a patient who have a long history of tobacco chewing, and due to his tobacco chewing, the oral submucous, there is a fibrosis in the oral cavity which doesn't allow for the intubation process. In that patients, what we do is we do the tracheostomy. Now coming to our second step in which we are doing the pre-anesthetic checkup, the second step is we will ask the patient about his medical and as well as the disease history. So what are the things we need to do in pre-operative process? The second step is we need to know about their medical history. Now these are the very common diseases and very common drugs which are used in our daily activities, the first disease is hypertension. So the hypertensive patients, what we are going to do in the pre-anesthetic checkup, we ask them to continue all the antihypertensive drugs except two classes. Those are ACE inhibitors as well as angiotensin receptor blockers. So what is this ACE inhibitor? What is its full form? It is angiotensin converting enzyme. So what are the drugs which comes under it are, I will give you a simple mnemonic to remember. Those are prils. The drug name which ends with pril, those are ACE inhibitors. For example, to say captopril. Now coming to the angiotensin receptor blockers. So what are those? Angiotensin receptor blockers, the mnemonic for this is, they end with sartans. The drug name ends with sartans. For example, telmisartan. So these are the drug names which ends with sartans. So these should be stopped on the day of surgery. Why? Because it will lead to intraoperative hypotension. This is the side effect which it will cause. That is the reason we have to ask the patient to stop it on the surgery day. Now, what are other medications we should see? Those are thyroid medications, anti-epileptics, antipsychotics as well as antidepressants. What do we do with this medicine? We can ask the patient to continue with this medicine. Now coming to the next one, there is a coronary artery disease which are blood thinners like aspirin, clopidogrel, heparin as well as warfarin. Aspirin we can ask them to continue because it is a very small dose, 75 mg is a very small dose. So we ask the patient to continue even on the operation day. But when there is a high dose aspirin such as 325 mg, we ask the patient to stop this drug. Now clopidogrel we ask them to stop 1 week before the operation, and heparin we ask the patient to stop 12 hours before, as well as warfarin we ask them to stop before 3 to 5 days. Coming to the third step in a pre-anesthetic checkup, what it is fasting status. We ask the patient to fast because to prevent the aspiration. In adults, the solids thing we ask them to fast for 6 to 8 hours. Coming to the children, formula milk is 6 hours, breast milk for 4 hours and clear fluids for 2 hours. It is like 6, 4 and 2. This is the way you have to remember because these are the definite questions for your exams. Now coming to the next thing, that is ASA grading. This is nothing but as we do these 3 kind of pre-anesthetic checkups, what we do is we assess and certify the patient whether he should undergo anesthesia, whether he is fit to anesthesia or not. So this is the American Society of Anesthesiologists grading which has given to certify them. To certify the patient whether he is fit for anesthesia or not. So how do we assess this? We have a grading. The grade 1 is there are healthy patients who doesn't have any systemic illness. So this patient is fit for anesthesia. Now coming to the grade 2, controlled systemic disease. For example, what does this mean, controlled systemic disease, or you can also say mild systemic disease. So when we say controlled systemic disease, for example, we have diabetes as well as hypertension. So when I take the BP, 120/80 is normal. So what it means, the controlled? When it came 110/70, I say it as controlled systemic disease. And coming to the grade 3, if you see, there is uncontrolled disease or functional limitation. What it means, when we see the BP measure, it came 90/60. So it is not in our control. So we say it as uncontrolled systemic disease. Now when you take the grade 4, what is it saying? Constant threat to life. For example, MI. When the BP later on, what it causes? The hypertension. What it means hypertension? The pressure in our blood cells has been increased. The pressure in our blood vessels has been increased, which will lead to left ventricular hypertrophy later on, and then it will lead to heart attack or such as MI. So these MI, now due to uncontrolled disease, if you can see, I have measured it one by one. If you see the controlled systemic disease as well as uncontrolled systemic disease, when you see there is a constant threat to our life, now this is considered as grade 4. In grade 5, you see moribund, survival unlikely without surgery. So there are cases without surgery, they are not going to survive. For example, burr hole surgery. Coming to the grade 6, there is brain dead patient. When they have to go for organ harvesting or organ donation thing, this is the grade we are going to give for the patient. So this is all about the grading of ASA. Coming to the anesthesia machine as well as cylinders, for example, think you are the anesthesiologist and you are in the OT room. There is a patient who is wheeling up and you are the responsible person to take care of it. So before that, you need to know what are the types and what are the things indicated in our anesthesia machine. So here we see, this is the patient monitor, in which you will know their pulse as well as SpO2. And these are the flow meters. This is the carbon dioxide absorber. This is the reservoir bag. And here you see, we have the gases which consists of air as well as nitrous oxide. So this is the machine which is given by Edmund Gaskin Boyle in 1917. Now this machine consists of cylinders as well as, so we also have the pin index system. These cylinders are connected in such a way to maintain the flow, to maintain the vaporizers as well as the breathing circuits. And this pin index system is given to us so that we prevent the wrong cylinder attachment. Now getting into more detail about the cylinder materials as well as colors. If you see the cylinder material and colors, what it is made up of, the material is made up of molybdenum steel. And coming to its colors, we have the oxygen cylinder. If you see this image, this is the oxygen cylinder. So it is how it is appeared. It have the black body. This is the black body with white shoulders. These are the shoulders, white shoulders. Now if you see the nitrous oxide, it is completely blue. Completely blue in color. The cylinder is blue in color. Coming to the air cylinder, it is grey color. So the cylinder is grey color with white and black shoulders. So if you can clearly appreciate in the image, there is a grey body as well as black and white shoulders. Now coming to the next cylinder, which is carbon dioxide cylinder. If you see, there is a recent change on this cylinder. Before it used to be different, but now they changed it to silver color. So it is silver cylinder. The next cylinder is Antonox cylinder, which consists of blue body and white shoulder. It have 50% oxygen and 50% nitrous oxide. Now this pin index safety system, we also called it as yoke assembly system. Now this pin index safety system is given so that the cylinder should not get the wrong attachment. To prevent this wrong attachment to cylinder, we have this pin index. So what are those? Now the air have an index of 1,5, oxygen have 2,5, nitrous oxide have 3,5, NOx have 7, carbon dioxide which consists of less than 7.5%, then we go for 2,6, and when the carbon dioxide have more than 7.5%, then we go for 1,6 index. So students, this is the very common and very important question which you need to remember. So there will be a definite question on these cylinders as well as the pin index system. Now coming to the circuits, here you can see there is a constant gas flow which will start entering in the machine, and this is the bag which we have, as well as this is the tubing which we have, and this is the face mask where patient is going to lie down, and this is the expiratory valve. So these are the things I want you to know before I enter into the topic. This is the anesthetic circuits where the patient lie down, where the expiratory valve is present, where we give the instant gas flow, as well as we have the alternative of the bag which we can see here. Now coming to the circuits, there are open circuit, there is a semi-closed circuits, as well as closed circuits. But we are not using anymore the open circuits, so I'll go detailed with semi-circuits as well as closed circuits. Semi-closed circuits are also called as Mapleson circuits because Mapleson is the one who have given these circuits, so we call it as Mapleson circuits. Now coming to its classification, there is a Mapleson classification A, B, C, D, E and F, but in this we are only using A, D and F, the others are not in use. Coming to first one, which is Mapleson A, we also call it as Magill because he is the one who modified the type A and given us the ventilation. So we call it as Mapleson A as well as Magill circuit. In this, we give the patient, we use this for adult patients, so we give the spontaneous ventilation. What means spontaneous ventilation? It is nothing but the patient is able to ventilate. Coming to the Mapleson D, which is also called as Bain circuit because he is the one who modified it. So here we give the patient controlled ventilation. We are giving the ventilation to the patient. That is what difference between spontaneous as well as controlled ventilation. Spontaneous is the patient is able to breathe on his own, but controlled is where we are giving the patient ventilation. And the length of it is 1.8 meter. Now coming to the next one, Mapleson F, we also call it as Jackson-Reeves circuit. And this is useful in pediatrics patient, only in children we are using it for both spontaneous as well as for controlled ventilation. So this is the pediatric one. And this we are using for adult. So if you can see here clearly, there is a fresh gas flow which is entering. There is the reservoir bag here. We have the face mask over here where the patient lies down as well as the expiratory valve. Coming to the next one, which is closed circuit. So here the exhaled carbon dioxide goes to soda lime canister for absorption. So which the carbon dioxide we are exhaling, it will go into the soda lime for getting it absorption. So what does the soda lime consist of? It consists of CaOH2, which is 94%. This is also, you have to remember, sometimes this is the way they ask the questions to us. What is the composition in soda lime? Those are CaOH2, NaOH, which have 5%, and silica as well as KOH, which is 1%. So there is a mnemonic for them, soda lime composition, to remember, CNSK. Now coming to the components which we need to avoid with soda lime, those are chloroform, trilene, which is nothing but trichloroethylene, as well as sevoflurane. Now let's get into the next topic, which is airway as well as mechanical ventilation. Now how do we ventilate the patient? The first one we are going to talk is laryngoscope blades. We do have types of laryngoscope, but let me tell you the most important ones which we use. Those are Macintosh. If you can see in the image, this is the Macintosh curved blade, which is used in adults because it is curved. Now there is the other one which is Miller's, which is straight. The straight curved blade is used in children, pediatric patients, because it is large as well as it undergoes to the epiglottis. Coming to the endotracheal tubes, if you see, there is a connector starting with it. There are the depth markings, if you can appreciate here very clearly, as well as the pilot balloon. This is the overall tube which we are seeing, and this is the cuff which we have, as well as the Murphy's eye. So what is the, we will see each and every explanation about it. If you see about the Murphy's eye, it is most important for the alternative airway, because when we enter this tube inside, what happens is, even if this area got blocked because of no ventilation, this is the alternative ventilator which we have. The next one is polyvinyl chloride tube. Polyvinyl chloride tube, we use them because it have low pressure and high volume cuffs. So this have the low pressure and high volume cuffs. This is the reason it is most commonly used. The cuffed ones are used in adults and the uncuffed ones are used in children. So let me show you the image of PVC. Here if you see, these cuffed ones, we use it for adults. And these are the uncuffed ones. There is no cuff present on it, so we use them for children. These are the tubes which we most commonly use. Now there are also red rubber tubes. So this is the red rubber tube, if you can see here. But nowadays we are not using them because it have high pressure. It have high pressure and low volume. This is the reason we are not using the red rubber tubes anymore. Now, as I have already mentioned earlier, the Murphy's eye, it is like a lateral hole which is used for ventilation if the tip got obstructed. Now coming to the depth of it, how do we insert the endotracheal tube inside? For example, to say, this is the trachea and this is the bronchus. So where do we insert? How do we confirm that endotracheal tube has been inserted appropriately? We get to know we insert it 3 to 4 centimeter before carina. So this is the carina part where it bifurcates, the trachea where it bifurcates, we call it as the carina region. So we insert this tube 3 to 4 centimeter above the carina. Now coming to the next instrument, which is flexometallic. This have a kink resistant. It is very flexible. In the name itself, if you can say, this is very flexible, flexo-metallic endotracheal tube. So it is kink resistant. It is very flexible and it is in prone position, which is useful for neurosurgery patients. Now these are the images I want you to know. This is the armored endotracheal tube and this is the standard endotracheal tube. Now this is the very important and many times asked tube, which is nothing but double lumen tube. Why we say double lumen? Because it consists of two lumens, which is useful in one lung ventilation. When we do the surgeries like thoracic surgery, we use this double lumen tube. The next one is ring Adair Elvin tube. For oral cavity surgeries, we will use this RAE tube. Now this is the RAE tube. Coming to next one, that is laryngeal mask airway. So this is the alternative airway. When we are unable to do the endotracheal tube intubation, we go for the laryngeal mask airway. Now laryngeal mask airway, if you see, so this is the silicone cuff which we can appreciate here. This is the airway tube. This is the connector as well as pilot balloon which is seen. So laryngeal mask airway, it is present over the supraglottic, but it is not a definitive airway. This is the point you have to remember, students, because normally when we intubate patients, we see and protect that it should not get into aspiration, but this is the laryngeal mask airway where it cannot protect the aspiration. That is the reason we say it as not a definitive airway. So when do we use this laryngeal mask airway, as it already have complication? When do we use this? If there is any minor procedures or when the intubation is failed, we are going to use this airway. When we should not use, when there is blood in oral cavity or when there is oral cancers. The next one is proceal laryngeal mask airway. This is the most commonly used airway. Here if you can see, I have also mentioned the other airways such as laryngeal mask airway supreme. So this is the first one is the laryngeal mask airway supreme. If you see the second one, this is the laryngeal mask airway proceal where the esophageal lumen has been added. So this is the tube where the addition of esophageal lumen has been seen. And there is also a classic laryngeal mask airway. Now this consists of cuff type which is silicone cuff. So for laryngeal mask airway insertion, you need to remember this. Propofol is the IV induction or sedation of choice.